concept mapping. And we're actually gonna do a little exercise together, so you might wanna be near a surface.
I actually already signed you.
Oh, thank you.
I didn't put your ID number.
Dawn Beretta also helped me work on this, so she gets some of the credit.
I contact her. If I just contact her.
Did we need to give Marilyn the stuff though for contact hours? or-
Oh, maybe you don't.
They were working on something.
I think they're working on
Yeah,
something.
I'll
Yeah.
sign it in a second.
Okay, good. We have seats here. Come and sit here, I can sit back here.
Sit right there.
Yeah, I can
Sit
sit
over there.
I can sit here.
There's a seat here. I'll put it,
Yeah, we can put it here next door.
because we're gonna use the table.
Okay.
Did you sign in?
No. I did look at it.
And we are videoing this for other people. They're all your peers, so whatever you say, you know, is confidential. They're not gonna say anything to anybody else. Okay, Lisa.
Alright, so I was introduced to concept mapping, a little over a year ago when we were putting together an orientation program for our unit. We had decided at that time that we felt there was a strong need to, put, what we called it a phase two orientation for newer staff to, you know, to really develop some, skills. So Donna Beretta and I worked on it along with our leadership staff, and this is something that the educators gave us as a tool. So we really felt, just go through the background, that we recognize the need for our staff to improve their critical thinking skills. I think like a lot of us who start here, you're very task oriented and we really wanted to bring them to that next level. So like I said, when we were introduced to the class, when we developed the classes, we were introduced to concept mapping, decided to be a useful tool in helping nurses to organize and synthesize all aspects of their patient assessment and care. We're fortunate that the surgical program educators gave us this tool, they mentored us through it, they helped us develop it, that it proved to be very useful. So we used our scenarios for concept mapping and with our simulation scenario, and we used it with our esophageal atresia patient and our care patients, which are the 10 Northwest folks, the Center for Advanced Intestinal Rehab, so all of our shortcut patients. So we had two different scenarios that we offered during that class. And we developed the scenarios to reflect the issues and the problems that the patients frequently will encounter.
I just wanted to share one thing is, I know that some of you have not been able to attend in the past because of scheduling and all that, and we are trying to change it. I'll talk a little bit about that to the end. But just so that you're aware of it, is that, for example, is all of you are here really as mentors, and what we actually have found is, for example, is that what we've learned is that many of the nurses that we hire now, even nurses that come from the outside, they've had 2 years of experience or whatever, is the patient population has changed so much on the inpatient units. All the easy patients we used to have before, now they're in the PACU Binney, they're in Waltham. And it's very difficult for anyone in this room here, okay, to even take sometimes a patient ratio of 1 to 4, never mind 1 to 5, or even 1 to 3 can be very difficult because these patients are just so more complex, more comorbidities. There's a lot more going on with them, never mind even taking care of the parent. So what we have actually found is that the preceptors do a great job precepting when we have new orientees, okay? But what happens is that going through the orientation, when they get off orientation, when you're like here after you've been here maybe even 6 months, it can be a year, year and a half, even longer than that. What happens is you become so task oriented because there's just so much going on with your patients that many times what's happening is that clinical judgment or those critical thinking skills aren't being developed. So what we're doing is piloting like a mentorship program. It's not because one person's better than the other or anything like that. That has nothing to do with that. It's really trying to give people skills to go with our synergy model, which is the critical thinking and the clinical judgment. It's how do you take something and you put the whole picture together, you know, and like if you were in nursing school, but right now it's really taking the theory and putting it all together, knowing your chain of command, knowing if there's a red shoes, putting all that stuff together. So when you're looking at this over here, I don't want anyone to think, oh my God, you know, why am I here or anything like that. It's really trying to get our staff to another level because we've learned that from all of you. Does that make sense then? I just want to give you an overview why.
I'm getting a lot of emails about people looking for the call-in number, so people are trying.
Oh, they are, then, okay, then,
Is Gail, is she?
Is
in
Gail's
the
here?
office?
You know, you guys can continue, because and I'll go get Gail to set up a line. I'll go get her, I'll take Gail to do a online.
Sure.
Just take, you guys continue, just continue.
Maybe
I'll
I'll
give
give
you
you
the-
those instructions.
So basically, what is concept mapping? Like I said, it was a new idea for Donna and I. We've been out of school for a very long time, so we were not familiar with this at all. But it's a tool that allows one to understand the relationship between ideas by creating a visual map of their connections, which is actually a really great teaching tool because a lot of us do learn visually. And concept mapping allows nurses to see the connections between the ideas that they already have. They can connect new ideas and knowledge that they already have and organize their ideas in a logical but not rigid structure that will allow future information to be included. And like everything, we had to do a literature review. It actually, to be honest, came after this, for some other work we've done on the program. We did a literature review. There's actually a lot of literature that's been written on concept mapping. I'm not gonna read through it, it's all in your packets. I think you don't need to read on these quotes. But you can see that, there's been a lot of studies both with nursing students and new orientees and in the critical care setting, where they've used concept mapping with a really, with good results. So, but I'm gonna go on to how we use the concept map. So, like I said before, we developed realistic patient scenarios that included every aspect of the patient's past medical history, their plan of care, a current assessment, vital signs, choose, and medications. And how we organized it during this orientation class that we do is that we did the first concept map together as a group because most of us are not familiar with this, and that's what we'll do after this, is we're gonna look at a scenario that I put together and we'll work on it as a group. Discussing how different assessments, i.e. like an increased heart rate could indicate different things. When Donna and I first did this, we put our scenario together, and we both did them independently, and even though we're very experienced nurses, we both still had, different priorities, very similar, but they were different, so you can see how people view things and, look at things differently. And then we followed that with a discussion how we were gonna prioritize the patient's care. Then we had the group do a second concept map independently, using a different patient scenario, which we reviewed together, and we discussed the similarities and differences between, the participants' concept maps and how patient issues can then be approached in many different ways. So this is a blank copy of a concept map, and I'm gonna give you guys all one using it. And, this is basically what it looks like. We have it on legal paper, so it's nice and big, and was workable for everybody. And this is our concept map in case that we used in our class. So with the concept mapping case, we, gave our past medical history and our objective and subjective data. I don't think I need to read every one of these points. The orders and the past diagnosis. So it's almost as if you're coming in and look at your assignment and how, just by looking at this, how would you prioritize your care, based off your assessment. So if you wanna go to the next slide, and I can pass, these might be easier if you want to share a few of these. These are the large ones too that we used. I didn't know how many people, but these are the,
I've given you smaller
Yeah,
ones.
the
with
smaller
tags,
ones
but
if you
they're
need it.
probably
you
better
wanna
to use
take
the
a look
larger
at these.
paper.
So we can go through it now and see how we, developed our concept map.
Do you want me to go back to the details?
No, I can,
Okay.
I'm gonna keep my history up, so. So the circle is like where your basically your patient is. So we kind of went back and used like the nursing diagnoses or problems, and we gathered our information, that way. So if you look like the problem under pain, your assessment for this patient, we felt looking at it, and this is our concept maps collectively, was like your elevated heart rate, irritability, the morphine dose was too low, and not frequent enough, the Tylenol dose was also a bit low. So that's what we would put, so our interventions then for that, you may wanna talk to, the practitioner about increasing the morphine dose. I'm sorry, I couldn't see that slide. Take you 2 hours.
1 second. Gail's setting up, the line, we call in, so she's setting up all the measures. I gave her the whole list, and she'll come in here and she'll set it up then.
Okay.
Okay, she's setting up all the measures.
You're welcome. So, some of your interventions might be, to increase that morphine dose, and decrease the interval to every 2 hours, to increase the Tylenol dose, so it's 15 milligrams per kilo, as opposed to, I think it was like 10 milligrams per kilo. And consider the IV versus, PO or PR. So so we went through every one of our, problems, so infection would be our next one. So if you look at infection, you're gonna see, you know, you have the low grade temp, which I know seems a little weird, but, you've got a little baby, sometimes they will present with a low grade temp even with infection. You've got a high heart rate, which also goes under pain. They're irritable, which can also go under pain, but there's erythema at the incision site, they have a PICC line, their lungs are clear but diminished at bases. So a lot of our assessment, I think going through this is gonna fit into many different boxes. So I think what often happens with people is they look at the first thing, the elevated heart rate, and they just automatically think it's just gotta be pain, without thinking it also might be infection, it could reflect dehydration, it could be a lot of other things. So they might only address that one problem, whereas by looking at it globally, you can then address maybe a few problems simultaneously. Does anybody have any questions, or has anybody seen concept mapping? You have, yeah. Did you use?
Where did you work with it?
We did it in nursing school.
In nursing school. How many of you did it in nursing school, just a show of hands then? Okay.
Did you find it useful or effective?
Yeah, I think so, yeah.
So, what I thought was, I mean, I could sit here and talk, or we could collectively work on one of our own concept maps. So I came up with a general, and I forgot to put the choose score, so I apologize. But I guess you can kind of look at it and get it. A general, a patient that could be on any one of our floors, when I was looking at patients that we all could get. So I came up with a 14-year-old male with a history of Hirschsprung. At 5 days old, we had a partial recession of the colon and a colostomy, and now it's 4 days old post-op from a colostomy closure. So let me hand out the concept mapping scenario, and then the blank concept maps, and we can work on together.
Do you wanna split the room maybe and have them go work on it together,
Sure.
maybe,
Yeah,
and
that
then
might
we can
be
talk
good.
about it, that
That
might
might
be,
be good.
break into
Okay.
different groups and people can work on it, and then there's more over here. Might be good to split the room up, how many people do we have in the?
I have more blank ones too, so.
So maybe,
Put it on.
so we have, let's see, what we can actually do is we'll exclude the managers from this, and then what we'll do is this, 1, 2, 3, 4, maybe 1, 2, 3, 4, 1, 2, 3. No, what we can actually do is, why don't we do 3 groups of 4? 3 groups of 4. If the managers wanna work on it together, that's fine. If Lexi and Judy wanna work on it together, since they wanna see what the managers would do, you can, you don't have to. All right, so
Somebody would
why,
see this
why
and
don't
see
you
the
just,
table.
and then Lisa can go around.
If you need me to help you, I'm sure that most of you know how to.
Yeah.
come up with nursing problems.
Right, so if you can just work
Getting
on it.
on IT bands,
So
you
we
know.
have the behavior packet, and give you some ideas, because you also
Who's
wanna
on the
think about
line?
developmental and education, and
Gail.
family
Okay, okay.
stressors, and all those things too.
So why don't you can sit here, so you guys can be together. So you guys can be together, okay.
We will, we'll get that.
One more person.
Over there, so one more person, yes, we have 1, 2, 3.
About 10 minutes for the
So we have
behavior.
1, 2, 3. Yeah.
And everybody has a scenario.
Right, everybody has, yeah.
Is this also all besides the
This is really the scenario.
Yeah.
Gail's on the line.
Yeah, who's on the line? Yeah, who's on?
Okay.
But she doesn't have it.
Yeah. Gail, we're just doing an exercise, right now in the next 10 minutes.
Mark, can you read?
Okay.
Lauren Montgomery.
Okay, Lauren. Lauren, we're just doing an exercise right now and a concept map. We apologize, we didn't have this line set up. So everybody's just working on a concept map right now. I'm not sure if you have, the tools are in front of you.
Hi.
Okay.
We'll make sure this, I'll make sure they do
Yeah, why, maybe you can send it to me, yeah.
Well, you have a whole list of.
I have a list.
Yeah.
I give it to Gail, so she can do it. You have it in here, I can go get it, okay? I'll go get it real quick, give it to Gail, I'll put it right in here. I have everybody in the list. I'll go get it. If you get stuck or anything, just ask Lisa or whatever, and then we'll have people just present what they want.
you, and Warren, I'm in the process of sending you the slides. So a better idea of what we're doing. They all live on Friday?
Yeah.
One bullet point thing, but maybe from this bloody flex to something for like proton.
Yeah, and the drain basement, anything around it or.
So this is the total of these buckets.
I'm writing down the temperature.
So in terms of interventions,
Yeah.
and
Oh, wow, that's right, I do know.
how are we surviving with that, if I units right much extinct, yeah.
Yeah, it's like,
So it's an alternative aid for this.
straight side. You had a lot of holes.
We still have alteration and elimination too.
What was this post-op?
What's that?
Yes, from just for a long time. Yes.
Right.
Or but it was the 2015 because it's kind of brown cages.
You have 5 more minutes, everybody. 5 minutes. Okay, good.
And yeah.
If it's easier for all, you can just work off of one sheet, really, you know, it makes it easier, so everybody's not writing down, just work on one sheet, just one person, if that's easier.
Right, so for the alterations and elimination, maybe they need to do or something diagnostic to make it happen. Right, there's some fullness.
The same line.
For the alteration and nutrition, maybe they should question line placement. And pitch.
Yes, you were, yeah.
Doing lots of other things, and then get those two.
So your brains all working slightly differently? You can see how people's perspectives differ when you look at the same scenario.
Yeah. And you still have, you have 3 minutes, okay?
And that's Kendra, is it not Kendra? Yeah. Oh.
I think those are just executive skills, right?
I think it's just a stand.
Oh, I think of it. And kind of telling you guys that.
Yes.
That's what I was looking But none of these, in terms of the vital signs, make it appear that he's got some respiratory distress. Or going back to some of these other things too, for infection, lots to take down the dressing.
So what did you think of like
Should we read
three main,
every-
so why don't we give me, like, let's discuss the three main problems you thought the patient was encountering at that time.
Okay, the problem, whenever major problems we saw would be infection.
Mhm.
Um,
And what was your
based on
assessment?
assessment, so he had a fever, his, heart rate was higher, so tachycardic, the redness at his, surgical incision, and the fact that he had also other sources of potential infection, his penrostrine and an epidural as well. And also his lung sounds are diminished, so you wonder if he's got some underlying atelectasis or something else brewing there.
So is your nerve, what is the nurse, what
And
would you
labs,
finish
just
on?
some other labs were, and then for intervention, we said, repeating labs, talking to the team about starting some sort of antibiotics, probably giving him some sort of, bolus based on his low urine output as well, and worrying with fever infection, being so positive. And then of course taking down probably just surgical dressing, assessing that more closely, and checking those other sources like we talked about, so.
Just 'cause before we
And then
go,
oh yes,
yeah, that's great, because what we'll do is we'll go to each group before we, have a open discussion with
Mhm.
everybody, that's great, anything else?
Did
from
you have any
anybody
other
else?
problems that you thought might have been, needed, like if you were the nurse taking this patient that you'd wanna go in and address, probably a little.
Why don't you grab another group, Lisa?
Okay.
you
Do
mean
you-
for infection?
Or no, or.
Oh,
with
like,
another
more
group?
problems,
Yeah.
oh yeah, we did,
Yeah,
but.
but let's not,
Yeah,
let's get another
yeah,
group
yeah.
there.
Do you wanna, do you have another problem besides infection?
We had nutrition, so he's 4 years post-op, still getting IV fluids. So maybe, and he still only has one IV in his right foot, so we wanna get like labs, electrolytes, scan labs, get a weight, maybe consider PN, lipids, PICC line, see how long he would really be without eating.
Right, and it's hard to judge at 4 days, cause they can open up or they can not do well. And how about the third group?
Another problem, it gets hard, if you don't go
Yeah.
first, it's hard, and we'll go around.
Well, but there's enough problems, there's a lot of problems
There's a lot
with
of
this patient.
problems, we're gonna keep going around.
That's the pain.
The pain, so what did
Yeah.
you guys think about the pain?
So his heart rate, put him at severe, just his heart rate alone put him at severe, he was at shoes, we're not being concerned,
Mhm.
us being concerned. The epidural was leaking, he was irritable, difficult to console, dashing, do you want to go through the interventions?
So we noticed that in the eyes and nose, it doesn't say that Tylenol has been given, so we would first give the Tylenol. We paged the pain team to assess the epidural site. We don't know if he was even getting any of it, if it was leaking beneath the meds, and we're also looking at if, we don't know if they were using the bolus button at all, or his intake was 72. And asking mom, kind of what has worked for him in the past, are there things to soothe him, or things that are comfortable that would help with it?
That's really important to bring the parents in. What about his Tylenol dose? Do you think did anybody look at the dosing of the Tylenol? Just to, how many times have you guys found a patient that they write Tylenol for and it's not a correct dose or it's too low? So, I always, one of the things I always think about is going back and checking those doses, making sure that they're, at the max. Do you guys wanna share another problem, with this group here?
Something else that hasn't been
Yeah.
mentioned, another problem.
They said like food and electrolyte imbalance, kind of similar to the nutrition one, but that he was like so positive with all of his fluids, that he had gotten over a liter and only put out, I don't know, 600 or 500. And we said that his abdomen was also still pretty distended, although it was soft. So his interventions, we had talked about, like everybody else had said, labs, and question like a KUB maybe if something was going on, he still has no bowel function. And maybe if they would ever consider like a diuretic, being so positive 4 days out that he has a diarrhea.
Do we know if he's positive though, or do we, cause his urine output but his NG tube output too is high. So do you think he'd be positive or? Cause he's also got other losses that, we have to take into account. So those are sometimes like, you gotta like, oh, wait a minute. So So his urine output is really low though, I didn't like purposely at 0.75. So, but I've been getting labs, if you look at his labs, the pre-op labs, they haven't done labs in a while, and then you look at the IV fluid, is there anything that sticks out that might, you know, that you might wanna think about, knowing that he's been an NG two, putting out a lot of.
Gas replacement, yeah, okay, yeah.
Or just adding K, but probably getting
But
his
get the
labs
labs first.
yeah.
Yeah, good,
Absolutely.
Make sure it's not a no problem too before you start dumping K into them.
Yeah, that's spoken like a South nurse. But, yeah, or, you know, because he's probably had high output, I didn't wanna go back and do like, you know, days of output from the NG two, but for some reason we probably forgot to. What about replacement of the NG two flosses at this point? Do you think, given his weight and his age, he put out 370 in the last 24 hours, would you be alarmed at that if you were the nurse taking care of him? Sure. So that's one of those sort of things.
And what would you do if you, for example, you see, and I know we don't have a lot of information, we have like the
I
past
know, that's
24 hours.
hard.
This is only past 24 hours, but you see, for example, his IV fluids is only like a liter, and then he's got like his urinary output and his NG output, we saw, you know, if you add those up together, what else would you do think, looking at this? If you have to go up the chain of command, you were gonna call someone, is there something else that you would actually do as a nurse?
Going up the chain of command.
No,
right?
well, because I
I look at it and think I would wanna obtain a second access because we're probably gonna bolus him.
Yes, the other thing I'm thinking about is, for example, if I'm that nurse, and let's say, for example, I was off the last 2 days, this is only a 24-hour snapshot, I would probably go back and look at the last 48 hours. So let's say, for example, the patient had been here for a while, because let's say you've seen that, for example, in the last, like, 48 hours prior to this, his heart rate, when 2 days ago, he was like 120, then let's say the previous day was 140, now it's 160, 170, and let's say, for example, his blood pressure's continuing to drop, okay? You have to look at different trends, don't just look at that 24 hours that you're here. Always go back, because that will paint a picture for you, because you wanna be careful also too, that decreased urinary output, decreased blood pressure, tachycardia, what do you think about when you see those symptoms? What might you think?
Shock.
Yeah, someone could be becoming septic, but you're not gonna know that with just a 24-hour profile. So always, when you're working, especially with our schedules as nurses, it's very, very difficult sometimes when you're only working that one day, you've been off or whatever. If you see numbers like this, go back and look at the last 48 hours or even the last 72 hours, and you can actually print those out. I maybe know how to print out from the computer the last 72 hours. If you don't, you should ask the educators or Lisa to show you how to do that.
There's good graphs, you can go to the graphing tool
You
as
can
well.
graph it and everything, so that's what I would recommend there, especially with these types of numbers here.
The graphing is good, I've learned how to do that.
Yeah.
Do you guys wanna, do you have
Another
any different problem that, I mean, I think we've hit on like, you know, the big major problems that, you know.
We also did skin.
Maybe getting the
Yes.
pain team to assess his epidural if it's leaking, if it's
Mhm.
actually even working or in the right spot.
Itching his eyes, we said maybe moving or.
Yeah. And I forget who talked about infection, but, I mean, think about an epidural with a fever, not only do you wanna call the surgical team, but you should also always let, if you were pain service orders, that would be one of our orders to let them know, because oftentimes they'll have to pull it, you know, for just the fever alone.
Going into post-op day 5, they would have to pull it anyway, so.
I know, they would be, but I think they have a little tolerance.
Sure.
Of it.
How about the hypoactive bowel sounds and no stool at all?
That's what one of ours was alteration and elimination too.
Yeah, so what would you do with that?
We would ask for a bedside eval by, you know, probably the NP first and then probably get a KUB or some other imaging, just to see what was going on there.
The other thing too that I would recommend, even though it might not be like a medical doctor's orders, as nurses, you probably learned all of this, you know, in nursing school, is when you start to see like hyperactive bowels, you see no stool at all, you might wanna take, like, for example, and check an abdominal girth on the patient. Because then that's an assessment skill, where, for example, let's say I'm working days, okay, and I do my abdominal girth, and my abdominal girth is 31. Now, the next day I come on, or the night nurse does it, and it's up to 33. What are you gonna start to think about? You know,
Somebody else is going on.
Yeah, that's something, there's something else might be going on also too, and you can go ahead and you can do that as nurses, and you might wanna just ask the nurse practitioner, someone just say, I think we need to do abdominal girths, because they're becoming more sensitive, and you wanna check to see if they're sensitive to rebound, every time you go to turn, it sounds like this child's very restless, maybe there's something going on in the gut, and that's maybe why they could be, really restless or whatever. It's just, your assessment skills. And that's what we're talking about, clinical judgment and critical thinking. Everything that we're talking about here is and check with each other, and check with your workflow nurses, your charge nurses, and even the nurse practitioners, you can ask them those types of questions. Okay, anything else?
Does the third group do have another just one more problem maybe that we haven't touched on? Anything? I mean, it's hard, cause we've hit like the big ones, so.
Yeah.
I mean, we could keep going on and on. I mean, there's education and learning, nutrition, developmental. I mean, we could probably write a book. But you can see collectively would be awesome taking care of this patient. But that's sometimes, we don't often have a chance to kind of synthesize all the data we see even ourselves on a daily basis.
And what score for choose would this patient be? I know we didn't put it on here, but.
And I think that's
all
what the
this
choose
stuff.
algorithm.
Yeah, so what would this patient be?
Like a 5, at least a 5.
Yeah.
The severe heart rate gives you a 3, the
Yeah.
mother's concerned. And then at this point, I'd probably be concerned, so that's automatically a 5.
That's great. And the other thing also, to just remember something. Tell me a little about the choose score now. Just because there's a choose score, okay? Always remember to put back on your assessment skills. A choose score is not an assessment of what you've learned in school. It is just to help us, trigger different types of things, like if you have to go up the chain of command, it's just a couple of little red flags. But it does not replace your assessment skills, your clinical judgment and your critical thinking skills. So all the other things that aren't built into a choose scores, you are accountable for that, okay? So now, let's say this is a red choose now. What would you do? If you, let's say for example, the patient continues like this. Can someone in any group just tell us like what would you actually do? It's a red choose. What kinds of things would you want to happen?
That's an eval, right? An MD eval, anything that's on.
Yeah.
I don't know if they're attending.
Good. What else?
Charge nurse involvement,
Chargers involvement, okay. One of the things that we've started on 10 South, and I would love to be able to see it on all the other units, on Judy's unit and Lexi's unit also too, is for example, anyone that's a red choose or a yellow choose, that if you're the workflow nurse or if you're the charge nurse, you have to check in with anyone that's a yellow or a red choose. And you have to do frequent checks on those persons. It's not because they don't know what they're doing. It's just so that they know what's going on, and then they might have to change the assignment. It doesn't mean that you can't handle that assignment. It just means that, for example, we wanna make sure that that patient is safe and that you have the time to spend with that patient. So I'm giving all of you permission, okay? That, for example, if your patient is a yellow choose or a red choose, that if a workflow nurse comes around, or a charge nurse, or there's a huddle, you can just say, something, I need somebody to help out with my other patients, or give up a patient, or whatever. All the managers are gonna support that. So, and this is what we're trying to do, high reliability, a safe environment for all of you. So please remember that. It's not so that you're there by yourself and no one is there. And if someone's checking on you, it's not because they're there to, for example, oh, Hermina doesn't know this, she doesn't know that, or whatever. It's just to make sure that, for example, it's an extra pair of hands, it's to check the labs, maybe they need to make a call for you, or whatever it's going to be, okay, just so you're aware of that.
I think it's pretty welcome on our unit.
Yeah, it
works
is.
well.
Yeah.
I think we just have to remember that people just need to communicate that information to the workflow of the charge nurse. Unfortunately, sometimes people get so caught up in what they're doing, they forget to, say, hey, this kid is a yellow choose. So you need to encourage people to talk. It's not a reflection on, oh, I can't handle my patient, but sometimes nursing is a collective action. And I think it's always great to get another set of hands and another set of eyes on a patient you're concerned about.
And when you go up the chain of command also too, let's say for example, the chain of command for you is your nurse practitioner. You call the nurse practitioner, and the nurse practitioner says to me, don't you then worry, you're being too cautious, the patient's been like this, don't worry about it. How many times has that happened to anybody in this room here?
Too many.
Too many times, okay, if that does happen, okay, what do you usually do? Do you just stay there and ignore it and just let the patient be the way the patient is? What should you be doing? Can someone share what they do when that happens? Because that happens, it could be an NP, it could be you calling the doc, you know, but if you have all your numbers and you go back and you look at the last 48 hours or whatever, someone's gonna listen to you, but let's say someone's not listening to you, what would you do? Anyone in the group?
Go up to chain of command.
And explain exactly what you would do with that.
So like if they said that they thought they were fine, I would, and they like just hung up fast or something, I would maybe like page again and try to talk to them again and then say, okay, if not, I'm gonna talk to the person above you.
Yeah.
Just because I really am concerned, it has
Yeah.
nothing to do with you, but I'm really like
Yeah,
concerned
and-
about it, and then repage them.
Yeah, and the other thing too is how many of you learned about SBAR? Situational background, you know, the assessment. In this hospital here, when we all went through the training, if, for example, let's say you come on the chain of command and someone, for example, is not really listening to you, you're supposed to say, I have an SBAR for you. And if you say that, they really should stop and listen to you. So you would say, this is a situation, this is the background, this is the assessment. And then at that point, they have to listen to you, just say, I'm sorry, you know, I'm gonna have to go now up to, okay, it's gonna be probably the fellow or and if the fellow gives you this exact same thing or whatever, then the next thing you do is you would go to the chief. At that point, you're gonna be nervous, you're gonna, the attendant, and then it'll be the chief, the attendant and the chief. At the same time you're doing that, what are the chain of command you're using at the same time?
Nursing.
The nursing. So if it's a nursing chain of command, let's say now, okay, you've gone to the charge nurse, for example, if they're really busy, they're not around or anything like that, you would go to Lexi, okay, or you would go to Judy, or you would go to Karen. Now, let's say they're on vacation, they're not here, they're at a meeting or whatever, you would go to me, okay? Even if you have to call me at home, you call me at home, okay? And when you're ready to call the chief, always make sure you guys call me, because at that point then, I call Yolanda and Yolanda know. That's the chain of command then, because then we're all being supportive. And I've had nurses that have called me before, and I've had to call the chief at home. I've called Dr. Reddick, I've called Dr. Cassidy, even got up higher, okay? And I will do that, but at the same time, I will definitely call then Yolanda. And one time, I actually called Laura Wood at home, okay? Just so she was aware of what was happening. Because we're here to make sure it's safe for you. And I know that sometimes that happens, so always remember, your gut usually tells you it's right. Let me tell you, 95% of the time, you're right on top of it. So, all
And
right.
then it's safe for the patient. The
It's safe.
patient should always come first, you know, no matter what. No, politics, nothing should stand in the way of the patient.
Yeah.
It's safety of the patient, so. it's really important.
Okay, and anything else that somebody had on this here that we haven't mentioned so far? You did great with really, you know, looking at your
So I just have a question for you. You know, how helpful do you think this would be during some of our daily huddles that we have? Because sometimes on attendees, we take a patient and we say, let's just talk about the patient. And I might say to Emily, present your patient. You don't have to go and look it up. You don't have to just start presenting because, you know. So I think it's helpful if we use like something like this, like a concept map for a group, because I do agree what you might think about, you might have something that you could add or to it, so it might be something that we wanna take into doing in our huddles, you know, occasionally anyways. So we have
I like it, I think it's a learning tool, I learned a lot from it, just doing the classes, doing it with, when that Donna and I did it, and it's a valuable tool, I think, for opening your eyes and looking outside your own, you know,
Cause you can only think so much, what were you
Mhm.
saying?
If we have like a patient that we haven't seen something that they have, like maybe like a lot more cardiac things and talking about those.
Right,
and
yeah.
Just
Yeah.
saying,
Yeah.
and like presenting them.
And you know, even as mentors, okay, you're not gonna know everything. You know, and you're gonna learn together with your proteges. We're all gonna learn together because, you know, every day I learn something new. And it's okay to say to somebody if you're, you know, that you're actually being a mentor to, you know, Herminia, that's a really great question, but you know something? Let's look that up together. It's not a reflection of you at all. And even on the units, when someone is struggling, you know when someone is struggling. You know what you actually do is, for example, take whatever that scenario was, and we should actually be, for example, is presenting those as case studies so that the other staff can learn from them also too. Because if we took situations that actually happened to me, let's say something happened to me and I was working nights, and then it's like, well, that happened on nights, I don't care about that. Yes, you do care about that, because that is going to happen to one of us sooner or later. And if we can share more things like this, what do you think's gonna happen with the staff? What do you think's gonna happen?
Open the gates of communication.
Yeah, and I think staff will be more comfortable with more complex patients.
Yeah.
And I think, what's this all about that we're trying to do here?
Critical thinking.
Critical thinking, and also feeling comfortable because I think many times, you know, these patients are so unique and we've never had them before. I don't want you to feel like you're alone, nor do the managers. We wanna make sure you know that you're gonna have resources, and the resources can be any one of us here, you know,
And it's all learning and sharing.
Yeah.
I'm gonna have you guys each take an index card. Shelley asked that, she would like some feedback, so she wants you to write on the card, what is one thing you've learned? What is one thing you'll implement right away? And then what is one thing you wish we had talked more about? So if you could do that, so we could get that back to Shelley, that would be great.
So maybe we should just put those up on the screen so they know what they are.
Can you just type those in real quick? We have them there?
No, but I
Okay,
can do that.
You can- Jane will type them up and put them on the screen so they can actually see what the questions are. Great job, everybody.
On the pavement.
We'll be right up. While you're all writing, I just wanna share with you is we know it's been very difficult to get people off the floor, and we've had feedback from everybody as you're writing, is what we're gonna do is, for example, August, we're gonna have a 1-hour session again, but come October, we're gonna do like a 4-hour session. So then we won't have to have these 1-hour sessions, so you'll come and we'll have like, half the staff in the morning, half the staff in the afternoon, so that'll make it a little bit easier for everybody.
And Marilyn's already sent that schedule out to
Yeah.
everybody, so.
Yeah, and as mentors also too, if, for example, you're struggling sometimes when you're with your proteges, we put down a whole set of questions in regards to things that you can review also too.
If you get stuck.
If you get stuck, we've got some questions to help you out also too, and some ideas, okay? Thank you, everybody.